Good morning. Sorry, I'm on this side of the podium. This is where they put us. I can go back there if you'd like me to. Mr. Chairman, members of the committee, I want to thank you for the opportunity to speak with you on this subject this morning. My name is Dr. Conrad Flick. I'm a board-certified family physician here in Wake County, practicing in Raleigh. I've been a family physician for over 25 years. I'm past president of the North Carolina Academy of Family Physicians, and I rise on behalf of family doctors across the state to oppose House Bill 88. And to be open here, I am certified 4 advanced practice nurses in my practice at this time, and I do not look at that supervision as a burden. I look at it as a responsibility for the care and safety of my patients. We believe this issue comes down to really one question. Who do you want to care for your family in times of need and when you're at your most vulnerable? We believe that advanced practice nurses play a vital role in primary care, but they are part of a team. They are not an equal substitute for primary care physicians. Primary care physicians, through careful history and examination, come up with complex differential diagnoses, manage multiple system chronic conditions, and build care management strategies based on our lengthy professional training that dwarfs those of our nurse practitioners. As shown in the slide that you can see, and I hope that you can read it, there are a lot of things that go into this. Malcolm Gladwell, in his book Outliers, showed that to achieve mastery in any field, be it sports, computers, business, or medicine, you needed over 10,000 hours of practice and training. When measured, the most elite in their fields had more than double the training hours of those far less capable. Without a strong educational foundation, even those experienced on that level will never reach an even playing field. Family physicians, all physicians, follow a rigorous and structured training curriculum that includes 4 years of postgraduate medical education and a 3-year residency training program. Advanced practice nurses, by contrast, at most complete a 1 to 3 year master's program and have no formalized postdoctoral training. The training difference between family physicians and advanced practice nurses is approximately 6 years and between 15,000 and 18,000 hours. It is also important to note that in today's world, technology is important, but is not a substitute for the hands-on medical training that we receive. Currently, not a single physician licensed in North Carolina has received any online training. APNs are allowed to complete some of their coursework online with minimal interaction with an experienced medical professional. Second, we realize there is great concern across medicine about the access to care in our communities. Advocates for independent licensure of nurse practitioners claim that practicing without physician supervision or oversight will improve primary care access, especially in our most vulnerable rural areas. However, there is strong evidence that this is overestimated. APNs on average spend the equivalent of only 3 to 4 years in primary care over the course of their entire career. Like the medical student counterparts, nurse practitioners are often lured away by better reimbursement at outpatient specialty fields. In contrast, graduates from family medicine residency can be expected to spend over 30 years in primary care, roughly 10 times what the average nurse practitioner does. APNs increasingly enter hospital-based positions to serve as physician specialist extenders. Hospitals are relying on advanced nurse practices to serve as specialists under the supervision of their own specialty physicians. Through this model, the hospitals can pay nurse practitioners more than what they earn in primary care, yet the hospital gets to reduce their costs. This creates a personnel vacuum, pulling more and more nurse practitioners away from what we're trying to do, which is provide primary care in a patient-centered medical home model. In fact,
Dr. Flick, if you'll wrap up your comments, your time is up.
The bottom line, we should not rely on nurse practitioners' independent practice to improve the access to primary care under the current economic and regulatory environment. Without specific provisions, the advanced practice nurses making them part of our permanent primary care workforce, a part of our medical homes. Independent licensures will have minimal impact on the primary care access in North Carolina and is not a substitute for physicians who have adequate training to function independently. I thank you for your time.
Thank you, Mr. Flick. Back for round two, Patrick Valentine.
Thank you, Mr. Chairman, members of the committee. Since we have a love fest going on, I want to say I love doctors too. I have doctors in my family. Just wanted to give you another possible reason that you aren't hearing any evidence on the other side. Remember the word I gave you, evidence. Fact situation number 2. The most vociferous opponents of this bill are my friends, the anesthesiologists. However, even the anesthesiologists have to admit that CRNAs are not routinely supervised by an anesthesiologist. In fact, the medical board statutes are silent as to supervision, and the CRNA rule uses the word collaboration to describe the relationship between CRNAs and any physician when performing nurse anesthesia activities. And that is Exhibit D, the Nurse Anesthesia Practice, North Carolina Administrative Code. It is noteworthy that often it is the CRNAs who administer anesthesia after hours or on weekends. In addition, many fine hospitals and facilities all over North Carolina are CRNA only. There's not an anesthesiologist in the operating room, in the building, or the county. Some of those include Cape Fear Valley Bladen County Hospital, Martin General Hospital, St. Luke's Hospital, Polk Hospital, Cannon Hospital, centers all over North Carolina with just CRNAs. Further, the CRNAs only administer anesthesia when there is a physician, a doctor that orders it. The CRNA starts the procedure and is there the entire time. The surgeon is doing his or her job, like maybe a colonoscopy at one end, CRNA is at the other end of the patient doing their job. The CRNA has his own malpractice insurance and is responsible for the anesthesia. The surgeon is responsible for the surgery. In most cases, general surgeons haven't done any anesthesia since med school. We have nurse anesthetists that have done tens of thousands of cases. CRNAs provide safe, cost-effective anesthesia in every setting without supervision. They perform almost 2 million anesthetics in North Carolina every year. So what am I going to do now is I'm going to give you some evidence. You've heard from a few interested people. How about Exhibit I, the National Academy of Science? There's no association of complications between the anesthesia providers. Exhibit J, Stanford Center for Healthcare Research. Using conservative statistical measures, there were no significant differences in outcomes between the two groups of anesthesia providers. The North Carolina Medical Journal, 1981, studied over 2 million patients over 8 years. The North Carolina Medical Journal, the incidence among the three major groups, the CRNA, the anesthesiologist, and the combination of the two, appear to be rather similar. Center for Disease Control, Exhibit L, 1982, Minnesota Department of Health. There are no studies, either national in scope or Minnesota specific, which show a difference in outcomes. Exhibit M. Surgical mortality study, Exhibit N, says the results reveal that patients are safe receiving their anesthesia care from CRNAs or anesthesiologists working independently or together. 400,000 patients studied in 22 states. Let me just go on because I've only got 1 minute left. This is really important. The federal rules that apply here are the Tax Equity and Fiscal Responsibility Act, known as TEFRA. The key rule is number 6. That is Exhibit F, the TEFRA rules. They say, it states, rule number 6, that an anesthesiologist, in order to get paid, remain physically present and available for immediate diagnosis and treatment. In 2012, the ASA published its own abstract in their magazine that said anesthesiologists may wish to decrease the supervision ratio of 4 rooms to 1 because supervision lapses occur in 65% of days. That's the anesthesiologist's own study. So do they try and reduce ratios to protect patient safety? No. The next year, in 2013, they tried to loosen the TEFRA rules by changing the definition of physically present and available. That's Exhibit H. I can go on with overwhelming evidence from major independent studies. I've got at least 24 national studies that show patient safety and quality will not be compromised. Quality of care is there. It's quality, access, and cost control. And we urge you, when the time comes, to vote in favor of this bill next week. Thank you.
Thank you, Mr. Valentine. For the final 5 minutes from the opponents, Dr. Bill Farrell, who is the Legislative Cabinet Chair for the North Carolina Medical Society.
Thanks to the members of the Health Committee. I am Dr. Bill Farrell, born and raised in Raleigh, spent some time in Chapel Hill, and then 9 years in Winston-Salem before coming back to Raleigh to a neurology practice. It's a 6th member of the group that now has 28 neurologists and 20 mid-level providers, including advanced practice nurses and physician assistants. Then integrally involved in training over a dozen of these folks in our practice. We use them in both the hospital and outpatient setting. But primarily, I'm here as chairman of the Legislative Cabinet to help offer the idea of North Carolina's long-standing policy of physician supervision of advanced practicing nurses, and the fact that elimination of that could be at risk of the best patient care that we have available. We support the continued supervision that has been offered, and Dr. Flick has reviewed the various data and hours of training. I'll also make a Malcolm Gladwell reference, the book called Blink, which states that experts acquire expertise in experiential hours. This often is tens of thousands of hours, and often they find it difficult to even articulate how they know what they know. I think the ability to, so reason one for our concern is that the ability to readily access the physicians, involve them in the care, is crucial because you're tapping into those hours. Sometimes it is difficult to pass this on without having the very experience that the physicians have had. Secondly, we feel that in states where the elimination of supervision has been made, there does not seem to be a huge increase in the penetration of advanced practice nurses into rural areas and underserved areas, maybe about 1%. None of those states, by the way, so far have been in the Southeast. And as Dr. Flick mentioned, many of these, at least 50%, seem to go into specialty care, such as ours, and don't necessarily serve the primary care needs. Thirdly, we feel that a very subtle subliminal message by our medical society staff dictates that in the bottom there you'll find the factors that are already identified by the North Carolina Medical Board that should help guide the relationship between the physician and their advanced practicing nurse. We feel that this allows for a flexible union, and as that training improves, then also the delivery of care and the collaborative effort is going to improve the quality that the patient receives. No doubt the educational input that the physician can provide improves that advanced practicing nurses' level of care, as well as making sure the physician themselves stay at the highest in their acuity of educational abilities and can pass that on. So we feel there's no reason to abandon these 10 factors in forming a unit that is really providing high-level care to the citizens of North Carolina. And finally, I think there's been some statements that this bill, HB 88, does not necessarily change the scope of practice, but we disagree. We feel that the elimination of supervision really does change it. That in my experience in working with the neurology mid-levels that we have, there's no doubt that daily they still depend on us. Even though these people have been in practice 15 years or more, we hear questions and feel that we need to collaborate on a regular basis, and I think they have always felt the same. So we ask you to reject this provision of elimination of supervision by physicians. Thank you.
Thank you. All right, we have just a few moments for questions, so members, if you will be brief in your questions, and for those responding to the questions, please be brief in your answers. And we're going to start with Chairman Murphy, who's recognized for 15 seconds to ask a question.
Thank you, Representative Burr. Let me just say, in full disclosure, as the only physician here, I love nurses also. I actually sleep with one. I have a sister as a nurse, my mother-in-law is a nurse, and my daughter may be studying to become a nurse. It is a...
Your wife is a nurse, correct?
Did I say I had to diffuse a little bit of the rhetoric from Mr. Ballantyne back there. She is. Yes, she is. And I also want to commend the bill sponsors, because I think the intent of the bill is that we want to provide quality health care to our entire state, both in urban areas but also in rural areas. So while I agree completely with the intent of the bill, I will say I disagree with some of its contents. I have one question I would like to direct to the Executive Board of Nursing, if I may, to Ms. George. I've involved a lot with the opioid issue, and you brought up an issue that it was never said that nurse practitioners have an opioid problem compared to physicians. I would ask, though, that the CSRS system, which is the Controlled Substance Reporting System, came out 4 years ago, and that's what helps us track prescription opioids. 4 years ago, the Medical Society engaged with them immediately to try to get a control on this problem. And this just gets to the point of I have a little question about what control is being, oversight is being done. Can you tell me why this nursing board has not up to this point engaged in a contract with the CSRS to try to figure out what the opioid issues are?
Well, if you recall, it was Session Law of 2015 that actually called for occupational licensing boards to enact rules so that the CSRS could furnish reports to them. So you're correct, they've been in existence for 4 years, but they've not had statutory authority to even report to occupational licensing boards those highest prescribers until, I believe, the medical board's rules went into effect in 2015, or late 2015, ours did in early 2016. So the data may be there from pharmacies, but they really weren't allowed to push or contract with occupational licensing boards until basically 2 years ago. We have historically, and I know the medical board does as well, anytime we have a complaint or anything that relates to a prescriber, our investigators can query that CSRS. I would tell you all, though, while I have the opportunity, that enhancing our CSRS in North Carolina is something we must do for patient safety. It sometimes takes us a month to get a report when we do request a report, and the only person that runs the report is a semi-retired person, John Womble. So we also in North Carolina need to belong to the multiple states that can share that data. Right now, the providers on that North Carolina-South Carolina line don't know what's going on in South Carolina.
All right, well, thank you. You answered my question. I appreciate it.
Thank you.
Representative Dollar.
Thank you. I'd like the gentleman who was the anesthesiologist to answer a question for me. And the question that I'm interested in, since we have a limited amount of time, I mean, this bill goes totally contrary to a bill we passed by over 90 votes in this General Assembly 4 years ago that passed overwhelmingly for supervision of CRNAs out of this committee. So this is quite a change in 4 years. But my question is, on page, beginning at the very bottom of page 1 of the bill, on page 2, and beginning of page 3, it sort of relists a lot of things that CRNAs do. It looks like some additional language, but mostly what's currently in the statute and in the regulation, although greatly enhanced. But I would just note this. It says, for the purpose of this article, these activities, and these are all activities that CRNAs, I think, mostly currently do. It says, these activities do not constitute the prescribing of a medical treatment regimen or the making of a medical diagnosis. And I'm just trying to square that with what this long list of procedures like securing, preparing, providing, selecting, implementing, managing general anesthesia. I mean, I see a real conflict that's being set up in this bill, saying that none of those long list of things constitutes making a medical diagnosis or a medical treatment regimen. Certainly making a medical diagnosis. What could you enlighten me on that?
Yeah, and I think that is confusing as well, Representative Dollar. All of those activities for which you refer to are activities that nurse anesthetists are qualified to perform as part of their training. The confusion exists when you start getting into the differences between supervision, collaboration, independent practice. And I think it's important that it's clear somebody has medical responsibility during the anesthesia care of a patient. And there is always a physician, dentist, surgeon, anesthesiologist present when an anesthetic is performed. And somebody has to assume that medical responsibility, and that person is best the physician. And I think it's as simple as that. That is, physician supervision is about ultimate medical responsibility. And the terms, get thrown around, collaboration, supervision, it's very confusing. But as you said, in 2013, the same House passed a bill requiring physician supervision of nurse anesthesia to try to clarify the confusion about this issue. I don't think that confusion has changed much, despite opinions that have been issued from the Court of Appeals in the past, the way the North Carolina Medical Board interprets and enforces physician supervision for its own certificates.
Thank you.
Representative Rogers and then Representative Potts are the last two members I have that have indicated they want to ask questions. We'll hear from them and then we'll wrap the meeting up. So Representative Rogers.
I'll address this to Representative Dawson just because he's first on the bill. And Representative Dollar, I think, pretty much just asked this question. But I was wanting to clear up, what authorities will this give CRNAs to diagnose and prescribe? And the second part of the question, Representative Dawson, is as it currently is now, is this supervision passive or active? I mean, I heard mention of across the state, and then we hear talk of in the operating room. What's the current state, and what would the state be after the bill?
Thank you, Representative Rogers, for the question. First question on what authority. It doesn't address authority per se. It just talks about, I'm trying to find the page number there. Okay, page 3, I guess what you're referring to, line 5. The purpose of this article, these activities do not constitute the prescribing of a medical treatment regimen or making of a medical diagnosis. We don't give authority. There's no authority giving to prescribe or make a medical treatment regimen. This just says that and that's the crux of the debate. That's what this General Assembly has to decide. What they are allowed to do currently in code, is that constituting the prescribing of a medical treatment regimen, or is it the making of a medical diagnosis? I do not believe that it does, and that's what we're trying to solve in here. And I'm sorry, could you repeat your second question quickly?
Just what's the current state right now as far as supervision go? I hear the terms passive and active supervision across the state. Is that supervision as it is now? Would that be supervision now? Or
I would agree a little bit with what the anesthesiologist said, that it isn't, those terms get thrown around a lot. I can only tell you from my district at Cannon Memorial Hospital, it is more of a collaborative relationship. An anesthesiologist is not even employed by the hospital. Other parts of the state may be different, but I can tell you from my district, we do not even have an anesthesiologist on staff. So I would say that relationship is more collaborative with the surgeon and with others in the operating room.
Representative Potts.
Thank you, Mr. Chairman. We all know that on a daily basis, the nurses save our lives, and there's a lot of favorable parts of this bill, but it appears that one group, the CRNA, is using legislation instead of education to accomplish their goal. My question would be, do they both have the same authority, a 6-year CRNA as 11-year anesthesiologist? Because it would appear that why would our young and bright students want to invest 11 years of their life and graduate with enormous student debt to be an anesthesiologist when they can actually accomplish this in 6 years?
I would just say that they are trained to do their job as a CRNA. They're authorized to do that under the code now, and we're putting into statute what they're able to do. And that's part of what this bill is for. We don't have individuals who are willing to come to underserved areas of our state. So under our current statute and under code, this legislation just solidifies their ability to do that. Clearly there's a need for anesthesiologists in this state, and there always will be, perhaps more in the urban areas where more physicians, others are willing to go. But for underserved areas, under the statutes and codes that we have, this will allow them to practice to the full extent of what they're already granted.
All right, seeing no further questions, the committee will adjourn.